So my talk is on ocular surface inflammation in dry eye. In recent years, there has been a lot of interest in this area, and that has resulted in a lot of publication during the last decade or so. Dry eye, as we know, is a multifactorial disease, and out of various etiological factors like tear film instability, hyperosmolarity, apoptosis, inflammation, it is basically the inflammation which is one of the major key factors. There is ample evidence in clinical and experimental studies that ocular surface inflammation plays a dominant role in the etiopathogenesis of dry eye. And immune cell infiltration has been shown in the various sites on the ocular surface in these patients. Of various ocular surface like inflammation markers, the T cell activation is a major one. And the T cell activation causes the calcium and calcium binding to the calcineurin. And this calcium-calcineurin-NFAT signaling pathway is responsible for inflammation. Cyclosporin and FK06 inhibits this one. Cytokines is another important inflammatory marker, and of various effects on the ocular surface, its effect on neurosecretory block is the major one. This disrupts the production of the tears and decreases the quality and quantity of the tears. MMP9, as highlighted by Dr. Srinivas Rao, is very important. Increased levels in dry eye causes the ocular surface damage. This diagrammatic representation tells us the amount of various ocular surface markers in dry eye as well as in the normal surface, particularly latent proteases, active proteases, and cytokines. So these are important for the ocular surface damage. In addition to these, even the nerve damage is important for ocular surface inflammation. It has been observed that the tear cytokine levels, they have direct correlation with the density of the immune cells, and they have inverse correlation with the corneal nerve density. In other words, the corneal nerve dysfunction induces the immune-mediated inflammation, and vice versa is also true, that the ocular surface inflammation can cause nerve damage. Once inflammation occurs on the ocular surface due to any reason, intrinsic or extrinsic, it enters into a vicious cycle. Surprisingly, ocular surface inflammation not only causes damage on the ocular surface, but also it increases the cytokine levels in the aqueous, which can result in the cataract formation, glaucoma, or even it can damage the endothelial cells. Now, in the beginning, the ocular surface inflammation is there, but the ocular surface may be normal. But with the persistence of the inflammation, it can cause SPK, it can cause persistent epithelial defects, limbal stem cell deficiency, and then even keratinization. And the treatment options will also depend according to the stage of the ocular surface damage. Like initially, immunomodulators may be helpful, but when the epithelial breakdown is there, we may need like autologous serum or amniotic membranes. And later stages, even limbal stem cell transplants or lid margin mucous membrane grafting may be required to decrease the inflammation. Of various symptoms, it is the pain which is very important, and pain equates the inflammation. This is one example of such patient who had severe dry eye and was on regular follow-up with us. One fine day he presented with bilateral epithelial defects which appear to be neurotrophic. We gave him all the medicines to promote epithelialization, artificial tear drops and autologous serum and everything. Contrary to expectations, after 10 days or so, instead of improving, he worsened. And the reason was that he used topical anesthesia frequently to take care of the pain. And he was himself an optometrist, knowingly all the complications. So we had to go for AMT and all that stuff. So this is how the ocular surface inflammation can damage the ocular surface. As pointed out earlier by Dr. Rao, MMP9 is a major marker, and we can quantify it. And after quantifying, we can also use it as a marker for deciding whether this patient can be put on immunomodulation or not. Like non-invasive procedure like impression cytology is another one. Whatever measure we may use for the treatment of dry eye, all these have anti-inflammatory effect directly or indirectly. But some of these like corticosteroid, tetracycline, they cannot be used for long periods, and probably topical cyclosporin is the one which is useful. Recently, several other molecules are being evaluated. Trehalose has anti-inflammatory effect and antiviral effect, and that's the reason it has come into talk in COVID-19. Liftigrast is another drug which has got FDA approval and is being used in USA for treating the dry eye. We have more experience using the Cyclosporin A. The problem with this drug is that this drug is not water soluble, but most of the preparations we get in the market they are aqueous preparations. And oil preparation is basically very irritating, and although it provides higher levels. This is one concept which is important for these kind of drugs, that if you have higher PC, that means the concentration in oil phase is more at the interface, then the drug can be effective at a lower concentration. So for topical cyclosporin, we need something like oil in vehicle emulsion. And there is a preparation which has got similar preparation, and one drop of this preparation releases 75 million droplets of one drop. And because of this preparation only, this has very high level at the interface and is effective at the low concentration. Now, topical cyclosporin can be used in several clinical situations to decrease the inflammation in chronic patients. In Murray's ulcers also, we can use it as an adjunct treatment. Topical cyclosporin can also be used for VKC patient with vernal ulcers, or we can use for adenoviral keratitis. This is one patient who had severe rheumatoid arthritis and had perforation, so we had to do therapeutic graft for him. And in addition to topical steroids, we used topical cyclosporin for him. In the end, I would like to emphasize that we need to treat dry eye effectively with all the modalities available, including cyclosporin, before we subject these patients to surgery. On the left side, we have got a picture which was operated without treating dry eye. Patient developed endophthalmitis and finally got cyclical. The other eye we treated effectively with all the modalities, including cyclosporin, and we had a good result. Now, in addition to the other effects of cataract surgery on dry eye, post-cataract surgery can also be aggravated by neurogenic inflammation. So we need to use cyclosporin in these patients pre-operatively also and for post-operative period also. And we need to control neurogenic inflammation. In some of the recent studies, they have used topical steroids pre-operatively so that we can cut down the inflammation post-operatively and we can decrease the effect of cataract surgery on dry eye. In the end, I would like to summarize that inflammation is a key mechanism in the pathophysiology of dry eye. Irrespective of etiology, chronic subclinical inflammation is crucial in ocular surface damage. Long-term treatment of ocular surface inflammation is of paramount importance to preserve the ocular surface and to prevent the visual loss. Cyclosporin A is effective in reducing the signs and symptoms of dry eye and also adverse effects of inflammation on the ocular surface. Thank you so much.